When a patient sits across from you, you don't receive an orderly list of symptoms. You are hit with a chaotic storm of data. Their presentation is a dense, overlapping web combining active acute pathology, inherited genetic risks, and deeply ingrained emotional coping styles. To organize this density, classical homeopathic practitioners rely on a historical triad: constitution, temperament, and diathesis. Mastering this layered deconstruction allows you to safely utilize qualitative historical frameworks to support your treatment without compromising individual patient safety or the accuracy of your remedy selection. The analysis begins at the desk, where we synthesize historical data and physical observations. First is the constitution. This describes the relatively enduring organization of the patient, encompassing both their inherited genetics and their acquired physical and functional features. In our accountant's case, we observe a notably tall and slender physical build. However, morphology requires strict discipline. Practitioners must never infer personality traits or prescribe specific remedies based solely on facial features or body type. This timeline visualizes the critical test for constitutional assessment, the element of time. Notice the flat baseline stretching across the timeline. True constitutional features are enduring elements, present long before the current illness. Now, look at the sharp spike. This spike represents the current disease state. Acute pathology creates temporary functional shifts, like sudden fatigue or changes in thirst, that mimic permanent traits. A disciplined assessment provides essential long-term context, but must be strictly separated from temporary disease-related changes to prevent misinterpretation. Next, we evaluate temperament. This defines the patient's characteristic functional response pattern, specifically how they pace their emotions, activity, and reactivity to stress. This four-quadrant matrix maps historical response patterns. Sanguine suggests a quick, sociable responsiveness. Choleric indicates intense, goal-driven drive. Phlegmatic describes a steady demeanor, and melancholic points to a deep, reflective nature. Applying this to our accountant isolates his specific functional style. He exhibits a clear melancholic style, approaching his environment and his symptoms with a highly methodical and analytical mindset. This observation holds immediate clinical utility. It guides the practitioner to adapt their communication, providing thorough, step-by-step details to match the patient's cautious pace. Temperament is highly context-sensitive. Pure types are exceedingly rare, as outer expression is frequently altered by age, culture, and environmental stress. There is a significant danger of overreach here. Do not confuse an acute state with a baseline trait. Mistaking acute pain irritability for choleric drive or acute fever restlessness for a sanguine trait will derail your analysis. Ultimately, a temperament label is merely an organizing hypothesis for a patient's coping style. It must never be used as a substitute for an actual psychiatric diagnosis, like major depressive disorder. The third dimension is diathesis. This refers to an underlying constitutional tendency or susceptibility towards specific pathological reaction patterns. This diagram illustrates the mechanics of modern susceptibility assessment, processing inputs like genetics, environment, and lifestyle. For our accountant, we input his family history of asthma and eczema. The matrix synthesizes this data, resulting in a clear classification, an allergic diathesis. Modern clinical terminology focuses on clear mechanisms like allergic or autoimmune tendencies. This replaces outdated historical text categories, like scrofulous or tubercular, formulated before the advent of modern genetics. Diathesis is strictly conditional. It expresses a mathematical probability of disease, not an inevitable diagnostic certainty. Environmental exposures, occupational hazards, and daily lifestyle choices act as powerful modifiers. They can either trigger or suppress this underlying susceptibility. Because of this, practitioners must avoid the ethical danger of deterministic language. Diathesis should never be communicated in a way that implies inherited fault or a guaranteed future illness. The true clinical value of identifying a diathetic risk lies not in predicting destiny, but in action. It empowers targeted preventative healthcare advice, recommends strict allergen avoidance, and designs effective environmental adjustments. This brings us to the final stage of case analysis, integration. The clinician must synthesize all these dimensions while maintaining a strict hierarchy of data. Step 1 is the disease totality. Active, characteristic symptoms, like our accountant's acute allergic rhinitis, always dictate the selection of the immediate simillimum. Steps 2 and 3 cover constitution and temperament. His slender build and methodical response pattern refine the long-term constitutional support strategy and dictate how you, as the practitioner, should communicate with him. Step 4 maps diathesic risk. Understanding his allergic vulnerability informs your advice on ongoing preventative habits. This schematic highlights the safety boundaries of this homeopathic framework. The first parameter involves diagnostic limits. Classification labels describe tendencies only. They must never replace a conventional medical diagnosis. The second parameter addresses action. Identifying a diathesis must never be used as an excuse to delay necessary medical investigation, structural evaluation, or emergency referral. Integrating constitution, temperament, and diathesis strengthens your clinical reasoning, but only when these historical tools remain completely subordinate to the individual symptom totality and patient safety.